Hey, and welcome to the Aaron Werner podcast on iCode Media. Today I had a great conversation with Dr. Damon Dierker and Roger Kennedy about Prokera and amniotic membranes. We shared our experience, how we communicate with patients, and how effective we believe the technology is. Please join the conversation by leaving a comment. Let us know your thoughts, how you use Prokera and amniotic membranes in the practice. Share the episode with a friend, and of course, leave us a 5-star review. Also, be sure to support those who support us. In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, Life Meter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being. All right, guys, we've talked about having this conversation for a little bit now. Excited to be here. I've got Roger Kennedy with us and Dr. Damon Dierker. I'm going to let these two gentlemen introduce themselves for a little bit. But before we do that, I want to tee off the conversation today. We're going to be talking about amniotic membranes and specifically Prokera and how we use them in clinical practice. I know I have some experience and some really cool stories from my office. Damon does as well. But before we jump in, Roger, who are you? Where are you from?
Yeah, thanks, Dr. Werner. Thanks for having me as well. My name's Roger Kennedy. I'm the Director of Marketing for BioTissue, based out of Miami, Florida. Been in the eye care industry for going on 11 years now, previously with CooperVision, and now the last 5 years with BioTissue.
Nice. 11 years in the industry. Is that what happened to the hair?
It is.
It was done.
It's either removed or grayer. So
nice. So, and Damon, I think we all know who you are, but for those who don't, tell us about yourself.
Yeah, I'm happy to be here for this conversation. It's definitely a passion. Part of my practice is using the amniotic membranes and what it can do for our patients. So I'm Damon Dierker. I'm an optometrist in Indianapolis. I've been practicing at Eye Surgeons of Indiana since 2002. I'm a partner in the practice. I have 4 MD partners. Our core practice is refractive cataract surgery, and we have 2 now going on 3 surgery centers, and a lot of what we do is optimizing the ocular surface, doing great surgery, and then co-managing with optometrists in the community. But I have a dry eye clinic, ocular surface disease clinic that's 2 days a week where that's all I do, and I've got folks coming in from 2-3 hour radius from Indianapolis to see us and have all the different diagnostics and therapeutics you'd want for that sort of clinic. And then I do a lot of things on the consulting education side with developments of dry eye boot camp from pre-pandemic, and now kind of a lot of my time spent with Eyes on Eye Care, looking at Eyes on Dry Eye and other events in the virtual space.
So cool. Yeah, we like those guys. Eyes on Eye Care are a good group. So Damon, there's not a whole lot of you across the country, ODs, that are in partnership with MDs and surgery centers. I know locally in San Diego, Dave Geffen's one of them. There's you. There's probably only a handful, if I'm not mistaken.
Yeah, we're a pretty small group, and I didn't even go down that path until I was with the practice for 15 years because it really wasn't a defined option. But I looked at all the things that I was doing to help build the practice, seeing patients, building relationships. We have over 500 optometrists that we work with in central Indiana and beyond, and doing things that provide a lot of value to the practice. And I felt like that was worthy of a opportunity to be a partner in the practice, and my current partners agreed, and it's been fun because since I've had a little bit more of a role in decision making, strategy, et cetera, is that we really have accelerated over the last 4 or 5 years, and we continue to do that.
So, very cool. You brought up something, and we hadn't talked about talking about it this ahead of time, but in the refractive surgery center, and you guys focus on, it sounds like a lot on the visual outcomes, the cataract surgery, LASIK, whatnot. And we've heard that it's important to have a good ocular surface, treat the dry eye before a patient has surgery. How important is it really? I mean, you're seeing outcomes, you're seeing hundreds of these, thousands of these. What's is it really that important? What's the true benefit, right?
I mean, do your patients really want to see? Do they want to invest, thousands of dollars in technology? I mean, the technology, I think about what we had 20 years ago when I started, it was a ray technology, IOL, that had a lot of glare and halos. We didn't really manage astigmatism as much, and we just said, hey, that's all we have. But we have so many different things now with trifocal IOLs, EDOF lenses. We do a lot of light adjustable lens in our practice, and that's been fantastic. And the limiting factor of all of these things is the surgery is great, laser assisted surgery. Our surgeons are fantastic. We can control inflammation postoperatively in the eye. But the limiting factor for so many of these patients is if we miss ocular surface disease preoperatively, that derails the whole process for the patient. So it's really imperative, and I know we've said that for the last 10, 15 years. Now with so many patients that are post-LASIK, so many people that, hey, my friend down the road just got a lens and they never have to wear glasses, I want that. Well, if we don't identify that and actually treat that progressively, proactively, we're going to have an unhappy patient. So I see some of these unhappy patients occasionally from our practice, a lot of times from others in the community, and I see them on the back end of that journey, and they're 4, 5, 6 months after their refractive cataract surgery or laser vision correction, and now we're just trying to uncover the ocular surface issues and get them treated. Is think about what that patient just went through, and we try to avoid that at all costs.
Yeah, I think I love what you just said. The limiting factor on all of this for the outcome is ocular surface disease.
Because the measurements that we can do, and the surgeries are so good, is like what is holding people back from even confidently recommending some of these procedures is we know it's the variability in the ocular surface. We know if someone has increased osmolarity, which is going to be kind of the driver for dry eye disease, that can have enough light scatter to equal what we see in a 2 to 3 plus NS cataract. So you can have a perfect surgery. You look at that lens, you look at the lens capsule, and everything looks great. But if their tear film is terrible, the patient is not going to have a good outcome.
Yep. No, that it makes perfect sense from an optics standpoint. How do you describe that to a patient? They're looking at coming in, having spending a couple $1,000s for surgery, and to get the best vision, and in their mind, you're going to start talking to them about tears. And artificial tears maybe, I take Visine or I do whatever. What analogies, what explanations do you share with patients about needing to treat the ocular surface before they have this surgery?
So I've never been a big storyteller or analogy type guy. So I try to make it very clear that, yes, Dr. Smith referred you over, and I agree you have a cataract in both eyes and you are going to benefit from cataract surgery. But what we found is that actually the very front surface of the eye is not very healthy and is not conducive for surgery. And if you want the outcome that you are capable of with the technology that we have to treat the surface of the eye before we go and do surgery. So I clearly outlined there's 2 problems. I clearly outlined which one we're going to address first, and I've laid it out, the value proposition, that if we don't do that, we're not going to have the outcome. So then if the patient is pumping the brakes at that point, I'm saying, are we really moving down the road of refractive cataract surgery? Or are we going to do more basic surgery? Because they have to be bought in, because if they don't understand what we're doing or buy in, we're not going to want to place a multifocal lens or do a light adjustable lens, because that patient is just going to have more trouble. So I pump the brakes. I let them know before we do anything is, hey, and I let them know we can usually do this within a month or so. Oftentimes we'll start with eye drops or other RX therapies. We'll get into, where does Prokera fit in this, because pre-op optimization, I think, is a very clear role for Prokera and cryopreserved amniotic membrane. But I think it's trying to do that right away at that first visit and not waiting until day 1 post-op or week 1 or 1 month and say, oh, by the way, you have some dry eye issues we need to take care of, never going to work out.
No, it's definitely hard to come back from from not treating it on the front end. It's interesting you said you're not a story guy, because I am, so I liked and maybe it's because you're a lot smarter than I am. But I like to tell patients that it's no different than they can have the most expensive car in the world. You just bought your brand new BMW, but if the windshield wiper blades are bad, you're not driving very well in the rain. And which relates well to me in San Diego, because it doesn't rain here very much, and so our windshield wiper blades are all crap until we have to get new ones. But they understand that quickly, and sounds like you do something similar on the follow up. Is, hey, we're not looking to move forward with these fantastic treatments and procedures and lenses unless we take care of this on the front end, because you're not going to be happy. It's going to reflect poorly on us, and it's not our fault. It's the fact that we've got a bad front surface of the eye, whether it's the tears, whether it's the cornea, it's all together, the whole ocular surface. So let's jump into how we treat it.
I just want to say another thing on that too. I think that's such a great point. I've heard from customers, and tell me if you guys agree. It sounds like based on what you guys just said, but as
and this is getting to why it's underutilized, is bucket number one for a Prokera or amniotic membrane is the train wreck patient. Someone that has a chemical burn, an ulcer, neurotrophic keratitis, they have Stevens-Johnson, all sorts of different things. Literally, that's like 5 to 10% in a referral practice. And I think that people define this, say, well, I'm not going to use Prokera unless everything else fails, or unless I just can't, unless it's a total disaster, then maybe I'll think about Prokera. And maybe I had some of that mentality 10 years ago when I first started, because I didn't really understand the technology. But it's just like anything else, technology works better if you utilize it in the correct spot. So it actually is going to be even more effective in these patients that are moderate to severe dry eye disease that have corneal sequelae, which is like 70% of my practice. Patients that have persistent symptoms, discomfort, light sensitivity, they have corneal staining. Some of these patients have filaments, some of them have persistent epithelial defects, but most of them just have corneal sequelae of dry eye that's not going away with conventional therapy. And when I say conventional, you kind of name those with artificial tears and RX medications, whether it's immunomodulators or steroids or nasal sprays, is doing some things that are not getting the patient to the point where they're satisfied with their treatment, and we're not satisfied with what we see. That's the most common scenario in bucket 2 is corneal sequelae of dry eye, moderate to severe. And when we talk about how a single application lasts for many months, I mean, the data is there to support its use in that segmentation of our patients. So train wrecks is a small percentage, big bucket, moderate to severe dry eye. And then I've got the smaller bucket is the pre-op surgery patient where they come in, they have significant ocular surface disease. Hopefully we find that before they ever have surgery, and they're not responding to conventional therapy. They have persistent topographic changes or staining that if we try to get measurements, God forbid we try to do it multifocal or light adjustable in that situation, is we just have to get that cleaned up before surgery. So I think, why is it not more used in optometry? I think a lot of optometrists on that pre-op side, if they're referring to the patient to a surgery center, they're like, well, that's their problem. They can take care of that. Where in reality, that's your patient that you just referred, and you're going to have a much better experience for the patient if you treat them in the primary care optometrist chair with RX if needed, with Prokera if needed, get them set up for success, go to the surgery center, like, wow, look at that, they're ready to go. You literally save the patient a couple months' time in certain situations, because if you have to slow down that process, there's just so much volume in these surgery centers, it's hard to expedite that patient unless you do your work on the front end. So that's a very long-winded answer, Aaron, to why people don't do it. It's because I think that they pigeonhole it for this subset of patients when there's 80 to 90% of its use really should be patients that are going to be seen by optometrists really in any practice setting.
Yeah. Isn't it funny how we pigeonhole things so much in practice? And I couldn't agree with you more that it primary care optometry should be managing everything they can before it gets sent to a surgery center. In my perspective, for a couple of reasons. One, of course, it's my patient, but two, what's the reflection on me if I send you over for surgery and the surgery center says, no, you're not ready, right? And you're not ready because you've got ocular surface disease. Oh, your doctor didn't talk to you about that. And I'd much rather send over a patient and have the surgery center go, you're coming from Werner, you're ready to go, right? Those guys know what they're doing. They've got you 2 feet away. Your ocular surface looks great. The surgery center is going to know that we're addressing it because they see the pre-op notes. And so it gives them a chance to reinforce how great I am, because that patient's coming straight back to me for the rest of their life, hopefully, unless they move away. But it gives me a chance to tee up the surgery center as the experts, the surgery center to reinforce me as an expert, and the overall experience is a whole lot smoother than if there has to be that hurdle or that pause somewhere in the road, especially if I said they're good to go and the surgery center says, not quite.
So. I agree completely with all of that, and unfortunately there's quite a few docs in Indianapolis that share that mentality, and they're a pleasure to work with, and they're progressive and proactive in treating things before they make the referral, because they know that they want happy patients, and as their patient, let's identify everything that we need to do to set them up for success, a smoother process on the pre-op side, for sure a smoother process post-op side, and then this is a once-in-a-lifetime opportunity for the patients to get the vision they want and the vision they deserve, and if we overlook the ocular surface, we're not going to be able to achieve that.
Exactly. The other thing I find interesting, and I'm curious your thoughts on this, you mentioned happy patients, and you've mentioned happy patient a couple of times, and I think that's ingrained in optometrists, right? We love happy patients, and it's cool that we're in a profession that we get to provide that quickly. But that also means that we don't like making people upset or inconveniencing them if we can. And the process of having a patient wear a Prokera for, even over the weekend, a couple days, inconvenience them. It's not a super comfortable product to have on your eyeball. You can't see through it, right? And for the most part, because you're looking through a membrane, which I always find interesting when a patient tells me I can't see through it. And I said, yeah, you're looking through a membrane. Have you never seen an alien movie? You can't see through membranes. But I'm wondering if that idea of I've got to inconvenience a patient short term so that they can have a better outcome long term is one of our limiting factors, and why we don't want to use a Prokera earlier in a treatment, and we wait until they're further along in their dry eye or they're that train wreck patient.
I think that's a great point, and I think if you're not used to using Prokera regularly, that's a hurdle you have to overcome. but I've done, a little over 1,000 of these over the last decade. I'm doing typically about 10 to 12 a month in my practice. I actually have a doc in my practice that does quite a few more, where he's even more proactive on that end, and I applaud him for that. So we do quite a few of these in our practice, and I think that I'm so used to studying the expectation that, hey, you're going to be aware of this in the eye. It's going to make your vision blurry. This is where I do use an analogy, Aaron. I say that's kind of like you're looking through swamp water. So they're going to have some reduction in vision, and there's different ways to mitigate that. There's a Prokera Slim, there's a Prokera Clear that has a trephination in it that doesn't tend to impact vision quite as much, and we really get the same outcomes. But if they have a traditional, what I would say, Prokera Clear, Slim, which is what we're doing for 90% of our patients, it does blur their vision, and they are going to be aware of that ring. So I let them know that, so that when they go home and they talk to their family, their spouse, or their friends, it's like, yeah, he told me that it's going to be blurry. Yeah, he told me that I was going to be aware of it. But it's usually not pain for these patients. It's more of just, I'm aware there's something in my eye. I put a tape soraphy up 95% of the time, just to give them a little bit of ptosis for the first 24 hours, so you can take it off anytime tomorrow. I make sure they're comfortable before they leave my office, and their comfort is not only comfortable here, but comfortable here, is that they understand what we're doing, why we're doing it, what the expectation is for that journey. And now the big thing that I was able to present recently on behalf of some of my colleagues from across the country is, we know that if we do that for a dry eye patient and we put that in the eye for 2 days, it has the same outcome in terms of improvements in their dry eye symptoms, improvements in corneal staining, just the same outcome as if we have it in the eye for 4 or 5 days or even a week. So now we have published data that says we don't have to have that blurry vision or that awareness of that ring for 4 or 5 days. It can be as little as 2 days, and my typical protocol is 2 to 3 days for these patients. And they have the same long-term outcomes out to 3 months or more, published data to support that. So I'm hoping that will provide docs a bit of additional confidence. Is like, yes, your patient is going to be somewhat inconvenienced, but you know what? Think about the inconvenience that they have for every day of their entire life. They're having to deal with this. I think if we can set the value proposition appropriately, 48 to 72 hours of some blurred vision and some awareness of a lens, I think that's a deal that almost all of our patients are going to accept. So it's that barrier that we put up in front of ourselves that probably it's not the same barrier that the patient has. The patient just wants to get better. Patient needs advice. And this is also a big point of mine. I want to see where you stand on this, Aaron, is I don't say that Prokera is an option. I say you need to have a Prokera. I strongly recommend it for a patient, and if there's pushback for whatever reason, I'll move to plan B. I don't give them a buffet of options to choose from, because I think that's disingenuous for the patient in terms of my expertise as their doctor, and their role in our patient-doctor relationship is we need to guide that process. So those are things that are holding our docs back, and they're certainly holding our patients back from having the outcomes they deserve.
Oh, absolutely. I can't stand I call it the optometric buffet, right? Where we set every patients up in front of a buffet and ask them what they want to choose. I like you, I tell them what they need, why I think they need it, and that we want to move forward. They obviously have a choice. If they decline anything that I've recommended, I make sure I let them know that I'm putting in the chart that I recommended it and they declined it for XYZ reasons. Doesn't mean we can't have that conversation. There could be very valid reasons why they don't want to do it. But yeah, I definitely stay away from the optometric buffet.
I think you have to, and think about where you're successful is you do that in everything that you do, whether it's the optical, contact lens, specialty contact lens, glaucoma management. Ocular surface disease is no different than that. Make a diagnosis, make a recommendation, give the best advice that we can for our patients. months. So that's my 90-second sort of elevator speech. How does that compare to what you're doing, Aaron?
Pretty similar. I tell them that everything we do in medicine tries to get back and replicate nature and the natural process as much as possible. And with Prokera, we've been able to do that. I don't call it a contact lens because my early patients, when I did, thought that it was they could see with it. So I said, hey, I'm putting a membrane on your eye. Right, that membrane is an amniotic membrane, comes from the placenta. It has all the natural healing and growth properties that you want. It's the perfect place to grow because that's where we grow babies. And if they have questions, I'll go down the safety avenue. But I think that they can appreciate that we're putting them in the perfect growth and healing environment. And then I typically will put it in on a Friday and have them back on a Monday. So hey, over the weekend, you'll have it in your eye. You'll be aware of it. You'll feel it. You're not going to see through it because you're looking through a membrane. But on Monday, I'll pull it back out, and your cornea will look pristine. I fully expect it to look pristine. And what I expect you to do is blink a couple times and go, oh, wow, because it's been years since you'll be able to feel how that feels. And usually at that point, they get a little excited and they're curious as to, let's do it. Let's put it in. Let's go.
So a couple things I took away from that is one is I'm not in a primary care optometry setting, so we don't fit contact lenses unless there's a bandage contact lens. So when I say biologic contact lens, for me, it's like that's just I don't do anything else with contact lenses. So I can see the differentiation of, hey, this actually call it a membrane, because maybe some more of these patients are going to be contact lens patients, and I have fewer contact lens patients in my practice than you do, almost certainly. And then I think that in terms of getting started with this, you and I have supreme confidence in the technology. We're very confident with the patient conversation. We know we can leave it in for 2 or 3 days, and we'll do it on a Friday and coming back Monday. I would say that when you're getting started with this, reverse that. Put it in on a Monday or Tuesday, have the patient come back Thursday or Friday, assuming you work normal hours, because you may have a patient give you a call until you get that talk track, set. Because now, based on how I set expectations, I literally have about 1 in 100 patients call me after hours because they're experiencing something they didn't expect. But if you're not used to that process and you don't have the confidence in that conversation, this may be something that, again, derails your opportunity to embrace this with your practices. I put this in on a Friday. The first 2 patients I called, they called Saturday and they said their vision was blurry, their eye was a little scratchy, and they're wondering what to do, and this is kind of a pain. And well, don't set yourself up for a failure like that until you get confidence in that process. Just kind of make it Monday to Wednesday. I mean, that's where, again, you can easily do now with the data we've presented, Monday in, Wednesday out. We can decide then if we want to do the fellow eye that same day, or if they want to take a little bit of a break. I would say my patients are 50-50 what they want to do. Maybe skew towards, hey, let's go ahead and just get through this because they know that they've seen the outcome on that first eye. So in on Monday, come back Wednesday, take out, do exactly what you did, is look at the eye, let the patient know what you're seeing. If the fellow eye needs treatment, offer to do that treatment that same day. It's a 0-day global period, so these are all office visits.
Yep.
Unless the patient is having the membrane, then I wouldn't charge an office visit on the day because that's included in that 65778 code. So I think that there's a lot of similarities to what we're doing, but I do think the verbiage and our choice of language may reflect the type of practice that we have.
Nope. Great point. Great call out. You talked about being comfortable with it. And I think we've been using it for about a decade as well. And what I found was interesting is I remember placing the initial order and having a bunch of Prokeras in my freezer. May or may not be next to a Snickers bar, but driving home and thinking, I could have used it here, I could have used it there, and it wasn't until I had the rep come in, and Roger, forgive me if you guys don't do this anymore, but I had the rep come in and I had our associate docs each put it in ourselves on a Friday over the weekend, and so we could experience it. And having that personal experience of putting it in an eye, but also having it in my own eye for a couple days and pulling it out was, I hate the phrase life-changing, but life-changing, because it's hard to explain or experience something just from an explanation without having that hearing it. And quite frankly, I stole another lens and put it in my fellow eye because it felt so good, right? But have that hands-on that experience if you're new to this. The other thing I thought was interesting, I was talking with Chris Wolf about his protocol, and mine's typically Friday to Monday. He looked at me and says, "No, that's football weekend. You don't want to mess up football, right? We mess up work, we don't mess up football." So his is during the week, just so we stay away from Nebraska football.
Yeah, and sometimes I'll do that second eye, or if it's these are, for some of our patients, this is a one-time treatment, and then they're on other therapies, they're good to go. There's other patients that you have, especially in the dry eye space, where maybe we're doing this every 6 to 12 months based on what we see and based on what the patient's telling us. And if the patient has more advanced disease, or they don't do well with prescription drops because they burn and sting, we've got many patients where this is their primary core therapy for dry eye, and we have a lot of confidence based on our results with that. I think that if patients have had a Prokera in the past, then I'm happy if they want to do that Friday to Monday sort of protocol. I'll let the patient steer me a little bit more, but that first time that I'm going to use that, I'd like to do it during the week, just like Chris.
Yep, so very cool. And you brought up the code real quick, so let's jump in on the billing and coding side. I think it's pretty straightforward, but it's worth talking about. So the CPT code is the 65778, and I wanted to get the language right, so I looked it up, and it's the quote, placement of an amniotic membrane on the ocular surface without sutures. And I know the Medicare average is about $1,400, and we've seen private insurances pretty close to that, maybe down to just below $1,000, up to right around that $1,400. And I'm in Southern California. I'm sure it's similar for you out in Indiana.
Yeah, pretty similar. And I think another couple pearls here is you want to code, whether it's a commercial patient or a Medicare patient, what you're treating is what we're limiting this discussion mostly to the dry eye patient, is you're going to code for the corneal sequela of dry eye. So that's superficial punctate keratitis, occasionally filamentary keratitis. But I would say a take-home pearl here is, in these patients that have ocular surface disease, always check their corneal sensitivity, because it's going to have a better idea of where they're at in this neurosensor abnormality spectrum of dry eye. For some payers, having a neurotrophic keratitis code is a more predictable path to reimbursement than others in the space. And I think it's just also setting up the patient as, hey, we did a test and your corneal nerves are actually damaged. I can't just give you a prescription medication or an artificial tear to fix this problem. We actually have to use a biologic treatment for this. So in these situations, the vast majority of my patients are going to have a Prokera as part of their treatment course. And then certainly patients that are more severe, recalcitrant patients that respond maybe incompletely to a Prokera, that's when we would move towards Tenedramine or Oxervate. But I think the two work really well together. It takes a few weeks, if not longer, to get patients approved for recombinant human nerve growth factor, the Oxervate. So these are patients that, boy, to get them moving in the right direction. We know Prokera is chock full of human nerve growth factor. That's one of the main reasons it works so well. So think about the spectrum of disease, because still neurotrophic keratitis is very much underdiagnosed. And if that's going to be what we're treating, or one of the things that we're treating, make sure that Prokera is front and center in terms of what you are going to use, but also make sure your charting, billing, and coding reflect that diagnosis.
Yep, absolutely. So for those who aren't doing a lot of corneal sensitivity testing and training, real quick, how do you do it, and what do you note in the chart?
I've done it every which way you can think of. I bought a Cochet-Bonnet aesthesiometer with the best of intentions. It's sitting in a drawer. I, for a long time, was using a cotton tip applicator, and you try to just make it a little wisp. but sometimes the material's not real conducive to it, and it takes a while, and maybe you got to glove up. I mean, so literally now I have dental floss in my pocket, so that I just will pull that out, and I use dental floss to use as my corneal sensitivity testing. And sometimes that will happen within the first minute that I'm examining a new patient to me, because the patient is going to come in for ocular surface disease. They're not going to get an anesthetic drop. They're going to get dye. They're going to get osmolarity, MMP9 testing, my biography. I'm going to do my history, and then I put some dye in. And then if I see that their cornea is lighting up, I just literally reach in my pocket, grab some dental floss, and I'm testing their corneal sensitivity, so I know within the first minute that I'm examining the patient that I have nerve damage that I'm going to have to address if I want to have a good outcome for this patient. So that's been the last month or so. I've kind of moved into that, and I think it's just easier. I do it at the slit lamp. Patients respond well to it, and it's not as cumbersome as doing the cotton tip. And I think that you just have to have a process in your practice to do that. What are you doing, Aaron?
The corneal wisp or the cotton tip applicator wisp is what we are. But now I needed dental floss the other day post lunch, and so I think that this is a fantastic two birds with one stone.
And it's the same reason I don't have my Snickers bar next to my Prokera in the fridge. I have a dental floss that says DSD Pod 1, and people know that this is corneal sensitivity testing.
As a marketer, I feel like I should be providing our field with some Snickers bar and some dental floss.
Nice. Some conversations to have with Craster Colgate over there. Nope, I love it. I think you have having a process is the key thing in what you just said, Damon. So that you're consistent, you can repeat and whatnot. And it's for our information. It's for our chart documentation. Certainly helps when you get questioned on why are you doing this from the insurance company. But I think the biggest reason is educating patients. They don't know what they don't know, and they didn't have sensitivity yesterday and lose it today. Right? It wasn't like they got into an accident and I no longer have feeling in my hand because I was in an accident and I could feel something yesterday I couldn't today. This has been a long, slow change over time that they're not aware of. And so being able to articulate that to them and demonstrate to them is super important, and I really think it helps them accept all of what we're trying to, I hate to use the word sell them because we're recommending, but we're really selling ourselves, selling our treatment recommendations. And they need to trust us, and this is a good way to do so.
And it's just like anything else, is if you're recommending or prescribing something and you don't have confidence in what it's doing or what that it's going to look like for the patient for the next couple of days or the next several weeks or months, the patients are going to very quickly understand that you're not confident in the process. How do you get confidence in the process and the talk track? You just got to do it, right? Just think about the first couple, Aaron, that you did 10 years ago compared to the first couple you did this month as a totally different experience for the patient. So I think that's with anything in our practice, whether it's optical, medical, is think about what that patient experience is like. Practice, you can do role playing with your staff, with colleagues, with your sales rep, is practice that Prokera elevator speech so that when you need to bring this up the next time you see a patient, you can pretty clearly know that you know what you're talking about. But you have to be intentional about this, because I think that if you're not and you just expect all this it's different, and it's different for patients, it's different for your practice, it's different for your staff, is be intentional about planning, how can I make this as seamless as anything else that I do in my practice.
Yep. I love that you brought up staff. I think that's a missing component in the success of a lot of what we do, or it's the factor for the reason we have the success. And I learned early on in this process that I wasn't including them when I should have, and now very much so. And what I mean, when I learned it, we had a patient call in and the next day, and talked to the staff because they're the ones who answer the phone. And my staff came in, interrupted me and said, "Oh my God, Dr. Aaron John Smith's on the phone." And I told him to come in right away because he feels like he's got something in his eye. And I chuckled and laughed and said, "Yeah, I know. I put it there." Right. it's a big plastic ring with a membrane around it. I certainly hope he feels like there's something in his eye. And the staff looked at me like a deer in the headlights. I instantly learned at that point that it was my fault because I hadn't brought them through on the process, and they were doing what I trained them to do on emergency calls, and not didn't train them to troubleshoot. And so now, whenever I put a Prokera in, I make sure there's a staff in the room so they can see the process. My interns are the ones who do it. My lead techs now. I have them do it while I'm in the room because I want them through the process. All the staff members, or most of the staff members, have had it in their eye, or at least seen it. Somebody else have it. So any of those, hey, I can't see, it feels better when my eyes closed, I feel like there's something in my eye, blah, blah, blah. They have familiarity with it, and so they can respond appropriately, and that helps to calm the nerves of the patient. It helps the patient experience, and it helps me from getting questions that I don't have to consistently, answer on repeat.
No, I think that's great, and I think that you can also leverage some of the things BioTissue has. They have Prokera brochures directed towards the dry eye patient. They have patient information for FAQ when you have a Prokera in the eye, what to expect. I think make sure your staff is familiar with all those pieces of material. Then I think the other thing is have some talking points in terms of how you describe that, be consistent with it, and even consider writing that down, and as part of your staff training is, hey, here's the things that we're talking about when we're looking at Prokera. Here's the things we're talking about when we're talking about IPL or LipiFlow or tear cares, is have the same talk track, same language throughout the practice. Everyone's on the same page. It's going to be very clear to a patient that you're experiencing, your staff is experiencing in the technology if you're all using the same language, right?
Yeah.
And if patients are going to lose confidence, is, hey, I had a question, this staff member had no idea what I was talking about. It's like, well, what's going on here? Am I a guinea pig? Is this brand new? Is be intentional about it. And we set it up to be more difficult than it really is. But you have to get through that first 5 or 10 patients, understand the experience. I think it's reasonable, like you said, if you have corneal sequelae of dry eye, maybe you want to get this in your eye at some point as a doc as well. I think that's reasonable. But I think that be intentional about creating a Prokera protocol. BioTissue is going to help you with this, certainly with the resources they have available. And you're going to have the same sort of success in California as I have in Indiana.
Absolutely.
Yeah, I just want to, if you don't mind, piggyback off
please,
that.
Roger.
Yeah, it's a great point. So just like Dr. Dierker mentioned, we have we want to be in this with you. So we have a ton of resources, whether they're the patient brochures, the FAQs, videos in the lane, website dedicated towards both patients and physicians. So on the patient standpoint, feel free to take advantage of all of those that we provide. As well as from your standpoint, right? From the doctor's standpoint, we do 100+ educational opportunities or events on an annual basis. I actually just got back from one yesterday, which is a physician summit where we bring in doctors, both optometrists and ophthalmologists, learning about what the technology is, how it's used in the eye and beyond, and things like diabetic foot ulcers and spina bifida, things like that. So just please, if there's any type of gap or just increased desire to learn more about it, contact somebody from BioTissue to help get more information on whether it's the next summit or the next training opportunity, some more patient brochures. We should have more than enough things to help you fight this fight with your patients.
No, absolutely. You guys are fantastic. My only caveat is I would not recommend a lunch and learn if they're bringing in the pictures of the foot ulcers. A coffee and learn is a whole lot better in the morning.
It's more to wake you up there.
Yeah, but no, it is very impressive what the use of amniotic membranes does, and why Prokera stands out among the others with the cryopreserve process and whatnot. And I think it's very important for all of our team to know. We've got the Prokera for Patients link saved. I'm in Southern California, so anytime I can not use paper and get yelled at by patients for killing the world, we do. So we text that, send that link through a text message to them so they can read it on their phone. They can share it with family. It's been interesting too. we haven't tried to set it up this way, but have Prokera as a referral source, because they go talk to each other. They talk to their friends. Hey, I got this thing in my eye. Look, my eye looks kind of fuzzy when it's on, when you look at it. And they want to share what's happening with them. We like sharing all of humans are weird. We like sharing the negative that happens to us, right? Over a cocktail. But if they haven't heard about it, if they're explaining to a friend and that friend hasn't heard about it from their eye doctor, it's something that a reason for them to reach out and give us a call. So I appreciate the support, and we found that whether it's a billing issue, whether it's a training issue, whether it's a staff training issue, just whatnot, BioTissue has been very receptive to the questions, in depth or silly as they may be. So very cool. Damon, I'm curious, and I know you're in a referral center, which sometimes means you get more train wrecks than I see in a primary care setting. But in your, primary care hat, where would you fit Prokera in? How early would you fit it in your ocular surface disease, treatment paradigm?
So I think that like you would expect in terms of what you see or what the patient is telling you, then you should be reaching for Prokera. So I think it's not waiting until I try 3 or 4 different medications or tears or anything else. That's actually treat what's going on, which is their corneas are not healthy. We can restore corneal integrity with this regenerative therapy. And why would I want to wait for months on end or refer to somebody else to do that when I can do that in my practice and help my patient now?
100%. Could not have said it better myself, and that's exactly our philosophy in the practice. Right? Let's get you better as quick and as effective and as safe as possible. And honestly, even with Prokera, a lot of times it's one of the most, from a patient standpoint, the financially advantageous routes. Right? There's a lot of the RX medications have high copays. I'm seeing a lot of patients that have high RX copays and whatnot. So if we can get them better, we're not dumping a whole lot of medications and BAK and preservatives on the cornea, and then we can maintain the improvement that we have over time.
If they're not getting better, I mean, certainly a lot of these patients will get better on conventional therapy. But if they're not getting better, that's not keep doing the same thing. That's this hit, hey, why aren't they getting better? We need to do something different. But I think that once you have confidence in the product and the technology, that's not 6 months into the patient journey. It's more like a couple of weeks, right? If they're not where I expect them to be, if they're not moving along, and I have technology that I know works well, I know it's well tolerated, it's well studied, and I can do that in my office and keep that patient in my chair. Yes, there's a revenue component to this, but at the end of the day, it's about making that patient your patient, giving them the very best care that you can. So if you want to seriously say, I am treating dry eye disease and you're not incorporating amniotic membranes, I don't really think you are being serious.
Yeah. So, gauntlet thrown. You said something I thought was really impactful there too. You said if they're not getting better on traditional therapy, right? But you didn't say in 6 months or a year. You said in 4 to 6 weeks, right? That's
think about the
natural
pre-op
time I would
patient
see
too,
you back.
right?
That's
It's like,
impressive.
why would you wait if we have something that works well? If someone's responding to dry eye therapy, they should be moving in a positive direction based on the different options that we have available. If you're saying that I'm going to give it 6 months for a patient that is moderate to severe in your chair right now, I don't think that you're providing the best care that's out there. I think that there are some situations where certain products take that long to work, but when you have other things that work more quickly, that are synergistic, or work well as both primary and adjunctive therapy, don't wait for, why let your patients suffer if they don't need to?
That is the perfect point to end on. Why let your patients suffer when they don't need to, and you have the technology, you have the products in your chair right now to make them feel better. So I'm sure we could go down in a bunch of different rabbit holes and talk about all sorts of unique cases and other times to use Prokera and amniotic membrane technology. So would love to have you guys back to talk about those, but why not help patients feel better when you have it right now? So appreciate it. Awesome. So Roger, Damon, thank you guys very much for making time to join us on the podcast, and look forward to Damon seeing you next time you're lecturing at an upcoming event. And Roger, appreciate all the support that you and BioTissue share with the optometric community.
Thank you as well.
Thanks, guys.